So I'm signed up on December 12th. Is that not gonna work?
Have you done all your rides yet?
No, it'd be my last
No, then you're good. So it just if you've signed up for anything extra on top of what you're required to do. Okay, does that make sense?
one. After the finals, right?
Do what now?
He said it's after the finals, so is it still okay?
What's the date?
December 12th.
That is too late. Yeah, so we'll have to reschedule you because you graduate the 9th and 10th.
Okay.
I'll get Megan to do that. All right. We got these people back up and running. All right, so what are some of the signs and symptoms of pneumonia? What are some things we're going to see in a patient that's got pneumonia?
Cough.
Productive cough, okay. What are their lungs going to sound like?
Juicy.
Juicy.
Horrible.
Yeah. I've called in radio reports sound like their lungs sound like crap. Okay. So what are the technical terms though for those sounds that we're hearing? Rails or bronchi, crackles, okay? Where are we gonna hear these sounds primarily? In the lower lobes, so if we're hearing them in the upper lobes, that's not good, right? Because what happens with pneumonia? Where does it start out? It starts out in the bases, and as the lungs fill, they're just gonna start to fill the container, right? So if you've got crackles in the upper lobes, they're not moving air, it's usually you have a problem, okay? All right. So immune suppression associated with aging increases the risk of contracting pneumonia. Again, so what do we know? We know that the alveoli enlarge, the gas exchange isn't there, the elasticity of the lungs decreases. So these folks have a really hard time combating pneumonia and recovering from it. Okay. Goodness. All right, so pulmonary embolism. So condition that causes a sudden blockage of an artery by a venous clot. Patients present with shortness of breath and sometimes chest pain, okay? I'll tell you, I've never had somebody with a PE not complain of a sudden onset of chest pain, okay? And where are we gonna see pulmonary, where is the pulmonary embolism gonna occur? In the lung, okay? All right, so these things can be very small and minute and not cause a whole lot of problems, or you can get them so big that they actually lodge themselves in the pulmonary artery. So I've seen a few videos of surgeries, and these people are just darn lucky that they survive, but they're called a saddle PE. So it's a clot that's so large that it gets into the branch of the pulmonary artery and it's blocking both sides. They're huge. They pull these things out. And I mean, they're like, how does that come out of a human body? Okay. So very few people get lucky enough to survive those. It's just, they're caught early, some way, somehow, divine intervention, whatever you want to call it. Okay. So they can be very simple or they can be very significant. All right. So the cardiovascular system. So the heart hypertrophies with age. So what does that mean? What does it mean when something hypertrophies?
Overworked.
Do what now?
Overworked.
It's overworked, okay? Becomes more rigid, becomes more stiff, doesn't contract well, right? So what do you think that does to your cardiac, your preload and your output? Decreases, okay? So poor peripheral circulation, so your good cardiac output declines. So plaque builds up in the arteries. So it makes there's more pressure put on the walls of the arteries every time the heart contracts, trying to push blood around the body systemically. So you see a rise in systolic blood pressure. Okay, so that top number of your blood pressure, you're going to see those patients be hypertensive. So common blood pressures you might see with folks is like 190 over 80. They'll have a very wide map, but that systolic number is going to be high. Okay, it's all the resistance due to the structures becoming more rigid, becoming full of the fat and the plaque. Okay. All right, so there you go. So you're going to have patients that are, so you have all this plaque and all this calcium and all this stuff building up in the arteries and the body. What are some of the complications that you might think that somebody might have from this?
break off and go somewhere else and.
And who knows where it's gonna wind up, right? Is it gonna end up in their brain? Is it gonna end up in their heart? Is it gonna end up down in their leg? Where's it gonna land itself, right? All right, so with all these changes in the cardiovascular system, you start to have an increased risk of aneurysm. And typically, it's the descending or the abdominal portion of the aorta. So you remember I showed you a few weeks ago talking about the diameter of the aorta, and what did I compare the diameter of the aorta to? A garden hose. Okay. So what will happen for these folks is I tried to find a good video of a emergency AAA repair, and I couldn't find one. Chances are because they never made it to the operating table. But so what will happen is the descending abdominal portion of the aorta, because it goes down to about the pelvis and then branches off. So you'll start to get a bulge in the wall of the aorta, and a lot of the elderly population can live with that bulge for an extended period of time. They may live with it throughout the end of their life. Where it starts to become a problem is, and you'll get patients that'll tell you. You guys ever had a patient call dispatch and tell you that they have a leaky AAA? No? Okay. So sometimes you'll get the geriatric population, they're like, I've got this leaking problem. Be more specific. Well, they tried to patch my aorta a couple years ago and it's just leaking. Cool story. All right then. So, and they're pale and they're diaphoretic and they're complaining of abdominal pain and they have this pulsating mass. And I tell you, when I talk about a pulsating mass, you will see it through their clothing. Okay. So this thing decides to rupture, and the likelihood of that patient getting from point A to a surgery suite is very it's very unlikely that they're gonna make it there. Okay. Every once in a while it happens, but when that thing decides to go, it's usually fatal. Okay. Sometimes what becomes unfortunate for a lot of people, a lot of geriatric patients, is they get to a certain age, and with all their underlying health conditions, and just their overall status, the surgeon may opt and just say, I can't take the risk of putting you under. We're just going to have to see how this goes. Okay. And it almost, I could imagine that would really seem very much like a death sentence to a lot of the elderly population. But the surgeon's like, I'm not touching that because you're going to die on my table if I put you under and try to fix it. Okay. All right. So venous stasis. So this is where, and this is primarily seen more in females and women. Have you seen any of women that have just terrible varicose veins? And they, you see all these vein centers in the city that, they can go up and get treated. Okay, so progressively over time, I've had some elderly women that they literally, like their legs just look like a huge bruise because they're so varicose. Okay, so that eventually leads to venous stasis. So loss of proper function of the veins in the legs can lead to deep vein thrombosis or pulmonary embolism. So either the clot stays there in the leg and causes problems, or it travels up. So what they'll do is a lot of these elderly folks that can withstand the procedure, Research Medical Center is one of the only facilities in the city that does this. They'll put in a filter down in the femoral artery to catch any clots coming from the lower extremities so they don't work their way up to the heart or the brain or the lungs. So they'll try to fix some of these blood flow problems in the lower extremities and then put that filter in to catch anything that tries to travel. Okay. So it can really become troublesome for a lot of elderly folks, especially women. All right, so heart attacks. So I'd say it's about 50-50 with the elderly population and how they present. So some of them will present very typical. Mostly men, they'll present with chest pain, shortness of breath, be pale, diaphoretic. Elderly women are very much like most women. They'll complain of indigestion or nausea or abdominal pain, things like that. Or they'll have a syncopal episode. Syncope is very common in elderly females that are having a heart attack. That's why, for me, if I'm going to a syncope call, doesn't matter what the age is, it's something to not just be like, oh, they just passed out. It's blood sugar, 12 lead, okay, to make sure we're not missing something. because it's very, very common for elderly females to present just like females of any other age. Very atypical, very minor symptoms, you know. And a lot of, like my grandmother, she's a tough old bird. And so this woman will be like dying in pain and just, I'm fine. And you get that in the elderly population where there's, I'm fine. My daughter's just overreacting, I'm fine. They're having a massive MRI. Okay, so they're gonna present very atypically. All right, so heart failure. So the signs and symptoms will differ with right or left-sided heart failure. Okay, I've always liked these pictures, even for medic students. So this is where it becomes, people have a hard time differentiating between right and left and what you're looking at. Okay, so I think these show some of the most common signs and symptoms you're going to see. But one of the most common things that you see with right-sided heart failure, the thing that I always have pinned in my brain to differentiate right versus left, is extremity edema. Okay, because your left-sided heart failure patients, you're not going to see that extremity edema. Okay, so these patients are going to be fatigued, ascites. Does anybody know what ascites is? Okay, so it's the swelling of the liver. Abdomen becomes jaundiced, so they have a extended swollen belly. Okay, so enlarged liver and spleen may be secondary to COPD. So a lot of these folks wind up, so your heart failure patients wind up with the combo, COPD and CHF, and it's a nasty combo for some of these people if they can't get it under control. Might see distended neck veins, and why is that? Why would our jugular veins become distended? Everything backs up, right? So it's got to go somewhere, okay? So if you have a right-sided heart failure patient that you know JVD, that patient is sick. Things are going to go real bad real quick for you, okay? Anorexia and complaints of GI distress. They have lots of GI problems due to the ascites, the swelling, all that swelling, all that fluid just puts too much pressure. They don't want to eat, okay? So you might have this little bitty, teeny, tiny, thin lady with this huge belly and all this edema in her legs. Like that's a pretty typical presentation, honestly. Huge belly, super thin, huge ankles and feet, okay? And then dependent edema, all right? And this is a great picture of pitting edema. So if you haven't seen this yet, or when I've said pitting edema or anybody else has said pitting edema, so this is probably a +2 or +3, so this is significant. So as you see here on the right, they push their thumb into their leg, and this is several minutes later, and the indent is still there. It's probably going to be there for hours, if not days. Okay, there's so much fluid underneath the tissues there that it's going to leave that imprint for a long time. Okay, so this is a significant finding for right-sided heart failure. Okay, and this may be, it's usually typically lower extremities, and then if you have lower extremities and upper extremities, it's pretty progressed. Okay. All right, so with the left side, fluid backs up into the lungs. Okay, so this is where you start to have issues with pulmonary edema. You may even get patients that are coughing up pink, frothy sputum. Okay, that's bad. It's real bad. Things are going sideways on you. Okay, so nocturnal dyspnea. So this is when patients try to go lay down in bed and they try to lay flat, and it's pretty much like they're suffocating. So a lot of these folks will actually sleep in a recliner. So you'll go into their home at 3 o'clock in the morning because they call you because they're short of breath and they're sleeping in a recliner. You can tell that they spend every night in that recliner, okay? Because they can't go lay down flat, because if they do, they feel like they're suffocating, okay? All right, so here's some of the common signs and symptoms you'll see with folks with left-side heart failure. An altered mental status may be present, tachycardia, exertional dyspnea or shortness of breath. So they tell you, I can't even get up out of this chair and walk to the kitchen. Like, I'm just so short of breath, I have to stop every 2 steps and catch my breath. They're going to be fatigued, cyanosis in the hands, feet, and lips, and it may be chronic. It may be present all the time, okay? But ask them, are your hands usually this blue? Are your feet usually this blue? Are your lips like this? And they're, as long as they're able to answer your questions appropriately, they'll tell you. So we're going to hear potentially crackles, wheezes. I said, if you're getting that blood tinge, pink frothy sputum coming up, that's a huge concern to me, because once that stuff starts coming up, at some point it's going to become a fountain. It's like putting Mentos into a Coke bottle. Had a COVID positive cardiac arrest over at Orangeburg Manor a couple months ago. And I'll tell you, by the time that I have never wanted to shower so badly in all my years in EMS. We were gowned and Melissa ran that with me, and you're soon to be ball and chain, yeah. And I was covered in pink frothy blood. It was underneath my P100 filters. I mean, I opened up a geyser and it just kept coming. And that's the problem with these patients, is they get so sick and they wait, and it gets to that point. And with COVID, it just makes the situation 10 times worse. But it is, it's like that's the best way I can describe it. You put a Mentos in a Coke bottle, and the explosion of foam that occurs is about what you're going to see when the patient does the same thing and erupts, okay? All right, so stroke, leading cause of death in older folks, preventable risk factors, so smoking, diabetes, hypertension, obesity, lack of exercise, and how many of your elderly population, most of them, by the time they get to that 65 or older, how many of them really want to change the way they do things? They're pretty stuck in their ways, right? Like, I know my grandparents, they're hardcore. You're not going to get them to do anything different. Like, you're not even going to tell them, like, you can't go to Walmart because of COVID. Well, my grandpa's going to Walmart, whether there's COVID or not. So they're very stubborn. You can't get them to change the things that you need them to change, okay? So some uncontrollable factors, so age, race, gender, genetics, things that are hereditary. Unfortunately, some of this stuff affects different genders. There's things that, like the African American population, you see sickle cell disease, and as African American gentlemen age, that starts to become more and more of a problem for them. Gonna make some of these other things worse. Okay. All right, so the Cincinnati Pre-Hospital Stroke Scale. So this is what most EMS services use. This is the stroke scale that we use here and we go by. Most, you can get into the NIH stroke scales. Some of the hospitals use, they're very, very detailed. They take too long for what we do to complete. So we keep it simple with the Cincinnati. So we're looking for facial droop, arm drift, or abnormal speech, okay? And we can call a code stroke and call and activate on a stroke with just one significant finding of improvement. Okay? So hemorrhagic strokes are less common and more likely to be fatal. Okay, so that blood clot, travels to the brain, puts pressure on one of the large vessels, and all of a sudden it decides to pop. These folks do not recover well from that. They can be very significant. When I worked in the ER over at MU, we had a lady come in one night. She had been having a horrible headache, didn't want to go to the ER. Family's like, you look terrible, I want to take you in. By the time they got her to the ER, she was unresponsive, barely breathing, took her to CT, and she had so much blood in her head that it had caused a hemisphere shift. So, you have the ventricle that runs through the middle of your head. Okay, so you have a left and a right hemisphere. So you get too much blood, too much fluid, too much pressure in there. It starts to shift those hemispheres. Okay, once the hemispheres start to shift, the brainstem there's tension put on the brainstem, and at some point that pressure you're going to wind up with an internal decapitation, or you're going to be pushing brain matter out through your foramen magnum, right? So the hole at the base of your brain. So she had a complete herniation due to hemorrhagic stroke, and she was put on comfort measures and died a few hours later. So if these are not caught early, majority of the time they are fatal. Ischemic strokes, people recover way better from these. Now, and used to be, like St. Luke's on the Plaza has really changed a lot of the things in the Kansas City metro area that we do with stroke. They've got some pretty impressive numbers. It used to be that from the time of onset of symptoms, you had a 3-hour window. They've been doing clot retrieval up there, at 6, 7, 8 hours and having people recover with no deficits. So I look at some point for that stuff to change. But nationwide, standards wise, it hasn't changed, but they're doing some pretty impressive stuff up there. All right, so if the symptoms occurred within the past few hours, the patient will be a candidate for stroke center therapy, okay? So again, I foresee in the future this is going to change. Right now, we're working with a 3-hour window. So on our trucks, we have we can take them to Western Missouri as a level 3 stroke center. So they can administer a clot busting medication, and then we're going to ship them to the city. But we go through a checklist. So if they're on blood thinners, they're excluded from, receiving that medication. We have a whole list we go through real quick. Are you on check? Check. If anything on there is yes, then they're excluded from that. We go to the city. Okay. So there are some things that, we can do here and then move on. TIAs. So what I'll say about TIA, people are like, I just had a TIA. So a TIA is nothing but a precursor to the big stroke. Okay. So TIA is a sudden onset of stroke-like symptoms that quickly goes away. Okay. It resolves itself. All right. So you're like, what? They just had a TIA or just had a couple of TIAs. That's just a precursor that at some point you're going to have a stroke. Okay. So it's something that needs to be evaluated, needs to be assessed. You need to go, make sure that they'll do scans of the carotid arteries. They'll do scans of your brain, see if there's a clot somewhere that can be retrieved before it winds up lodging itself somewhere and causing you to have a full-blown stroke. All right, so I've ran people that don't necessarily fit the bill on the Cincinnati, but they'll tell me, I just can't put my words together. I can't, they'll just look at you with this 50-yard stare and they're like, I just can't put my words together. I can't put my thoughts together. I can't put my words together. And, in your last family, is this normal for them? No, not at all. So there are, some things but that just comes with experience and time that you're like, that is odd. That's not something that's normal. We're going to go to the city. We're going to go to a comprehensive center and get you evaluated. Okay. And I may call them and say, it's one of those things like if it looks like a duck and it walks like a duck and quacks like a duck, it's probably a duck. But that comes with time and experience. You're like, that's not normal. There's something not right here. And maybe you can't put your finger on what it is, but knowing that something's not right sometimes is 95% of what we do is just that gut feeling of something's not right here. Okay? So changes in memory, slower responses to question. So over time and with age, the brain decreases in weight, so it starts to shrink. Okay. So what do you think that does to trauma to the brain? So you got this noggin that doesn't shrink, but the brain inside of it shrinks. More susceptible to damage, to injury, right? It's got more room to rattle around in there. Okay. So being mindful of that in our geriatric population when it comes to trauma, that those processes exist underneath. Okay. All right, so vision, so decreased visual acuity, depth perception, and ability to accommodate light. You get patients that have cataracts, decreased tear production, so they have dry eye a lot, inability to see up close, may have glaucoma, macular degeneration. And I'll tell you that, I don't know why they think that this is just a 65 and older problem. All of a sudden, you're 36 years old and you can't see anything, So hereditary issues, genetics, all the things, okay? So I have a huge light sensitivity problem. I'm not 65 years old. So these things you see in the younger population, like I said, it's not just, we like to put things into categories and say, oh, that can't happen until you're over the age of 65. You shouldn't have breast cancer screenings until you're, 40 years old, things like that. And there's women that die of breast cancer at 26 years of age. So all these numbers and ranges are great, but be mindful that you will see this stuff in where it's least expected, or you're only 50 years old. It happens, people die, 25-year-old people die of heart attacks every year. I mean, it's just, these things happen. Okay? All right, so hearing starts to become a problem for these folks. So the ear structures, same thing happens, because what do we have in our ears? Does all the structures in our ears just handle hearing? No. Okay. Balance. Ever ran the old person, or at some point you'll run the old person that has vertigo super bad, that never had it before, and they wind up with an inner ear infection that they didn't realize they had, and now they have this terrible vertigo. And if you've never experienced vertigo or seen somebody with vertigo, it is awful. Okay. So, people are like, well, it's just hearing. Now your ears control lots of things. Okay. They can cause you lots and lots of problems. All right. So taste. So decreasing the number of taste buds, patient may lose interest in eating. You'll see it a lot. There's like, nothing tastes good. They don't eat much. You go into their kitchen, they don't have much in their fridge. So a lot of your elderly population, not intentionally, but winds up malnourished, dehydrated, just because nothing tastes good. The things that they used to enjoy, it's like they eat it now and they're like, there's no taste to this. So they just don't eat. Decreased sense and touch. So if most of us in this room were to walk back to the kitchen and put our hand on a hot stove, the nerve impulses in our hand, the pathway to our brain to say, move your hand off the stove is rather quick. But with the aging process, those pathways slow down. So your elderly population are more susceptible to things like burns and injuries because those nervous system pathways slow down and deteriorate over time. Okay. All right, so dementia. So this is chronic, generally irreversible condition that causes a progressive loss of cognitive abilities, psychomotor skills, social skills. This is typically, there's a lot of, if you look at a lot of the Alzheimer's dementia research that's out there, there's a strong link to genetics with this. It's something that they still to this day can't quite pin down to cure or slow down. There are some treatments out there that when they identify a patient with dementia, they start to treat, and they've started to be able to slow this down some, but ultimately, it's unfortunate for these folks. It's really sad to see folks with dementia, Alzheimer's, that and sometimes it's very progressive very quickly when the onset occurs. There's a couple of patients I've ran over the years that from one year to the next, they're just completely different people. They have, they're not even aware of their surroundings. These folks become very depressed, wind up in nursing home facilities and things like that. Family stops coming to see them because some of the time they don't know who they are. So family's like, they don't ever know who I am, so I'm not going to show up. So these folks really this is to me, this would be a death sentence. Like would be terrible to get diagnosed with. Because a lot of these folks, they wind up in facilities and people are just like, well, they don't remember me anyway. All right, so they may have short and long-term memory loss, have a decreased attention span, be unable to perform daily routines. So simple things like dressing themselves, feeding themselves, remembering how to, where they're at, how to get to the bathroom, how to bathe themselves, all kinds of things. May appear confused or angry. And you may also see this during different times of the day. You ever heard of sundowners? Your Alzheimer's patients, something about the sun goes down and they like flip a switch. So you may have this sweet little lady during the day, and then at night she becomes this person that you're like, what happened to the sweet little lady that I had during the day? Okay. Impaired judgment, unable to vocalize pain, or they may forget that they've been having pain. So a lot of people dismiss a lot of the issues and a lot of the complaints of dementia Alzheimer's patients that they don't even remember. And then they actually have something very significant going on underneath it all. So make sure you do a good, thorough assessment on these patients, even though it's not an easy assessment, but it's well warranted to spend the time to try to work through it with them. All right, so delirium. So this is typically something that's sudden. It's acute. At some point, it's gonna go away. So sudden changes in mental status, consciousness, or cognitive processes, marked by the inability to focus, think logically, and maintain attention, affects 15 to 50% of hospitalized people 70 years or older, okay? So especially your dementia Alzheimer's patients, they are in a facility they're not familiar with for too long, or they're being given medications that they're not used to taking, or medications, you get this elderly population that's has a polypharmacy. You know what I mean by polypharmacy? They like come with a whole like the little makeup bag type, like the little overnight bags, like the whole thing is full of meds, okay? So you get a patient that's on that many medications, and the problem is so the doctor puts them on 2 or 3 for whatever medical problems they have, and then they start to have adverse effects from those 2 or 3. Well, then they add a couple more to try to manage the adverse effects of the first 3. Well, then now they're having more adverse effects, so they put them on a couple more. And most of these little old folks have no idea why they're being put on this medication. Most of them tell you, I don't have any underlying medical problems. And then they hand you this box of meds, okay? So a lot of them, doctors don't take the time to explain things to them. They just like, oh, well, the doctor just told me to take it. They have no clue why they're taking it. So it can just compound and compound. Then they get, admitted to the hospital. They're given medications that don't interact well. And next thing you know, they wind up with this delirium. They can become very aggressive. They don't know where they are. They don't know who their family is. And a lot of the times there's a medication issue underlying it all. Okay. Also may have some metabolic causes. So especially with electrolytes like sodium and potassium, those get off, wacky things happen. I've seen people with low sodium do some of the most weird, crazy, spontaneous, like just weird things. You can also have issues where you wind up with cardiac arrhythmias, patients that become comatose due to low sodium. Sodium and potassium shifts, especially in the elderly, are not tolerated very well. Okay. All right, so syncope. Assume this is a life-threatening problem until proven otherwise, often caused by an interruption of blood flow to the brain, okay? So it said it doesn't matter if we're dealing with a geriatric patient or 25-year-old patient. It's something to always take seriously, do a good assessment, make sure there's not something underlying going on, okay? So, checking the blood sugar. For me, I'm going to get a 12 lead, make sure there's not some underlying cardiac cause. Do a stroke assessment, make sure that you're not missing something there, okay? All right, so neuropathy, so disorder in nerves of the peripheral nervous system, okay? So just like with all our other structures, the nervous system and nerve ends and nerve fibers start to break down over time, okay? So a lot of folks, what's the gabapentin? Anybody have grandma or grandpa that takes gabapentin? You take gabapentin? Okay, would you take it for back pain?
I don't know.
Yeah. So lots of folks get put on the gabapentin for their neuropathy. And gabapentin is not necessarily the most friendly drug to a lot of people. Do you have any problems taking it?
Yeah.
Yeah.
That's all I'm taking it.
Yeah. So say you're 80 years old and your nervous system is breaking down and you just have all this chronic pain and it's nerve pain, and they put you on, the doctor says, here's the gabapentin, add to your polypharmacy. Those folks don't know that they should stop taking it because they're having all these adverse effects to it, and they just keep taking it. So it just winds up compounding more problems for them. So understanding, even as an EMT, understanding pharmacology to a certain level, being able to look at a patient's medication list and go, oh Lord, like, why are you, like, what? And then you start looking at pill bottles and they go see this doctor for this, and they go see this doctor for this, and this one for this, and they all got them on different medications. So you have 2 or 3 doctors that aren't even communicating. So understanding the pharmacology to a certain level will be important for you to at least advocate for your patients at times. Okay. So symptoms depend on which nerves are affected and where they are located. So you may have some motor problems, sensory problems, or autonomic problems. A lot of times you have patients that with chronic back issues or lower extremity pain that's a lot of the complaints I see. And a lot of times it's because what happens to the spine and all the padding in the spine as you age? Like it becomes non-existent. There is no padding, okay? So you wind up with bony structures sitting on top of bony structures sitting on top of nerve endings. So they wind up having all kinds of sciatic pain. You get a lot of other people with sciatic nerve pain. They'll tell you, like, I have this pain shooting down my butt and down the back of my leg. And anybody in here ever had issues with their sciatic nerve? Holy crap. It's like, it's a bad day, okay? So, you know, it's the doctors are like, oh, well, here's a muscle relaxer, here's you got a pin, here's all these things, okay? So you can easily see why, if you look at people's polypharmacies, how they can wind up having delirium. All right, so the GI tract, so reduction in the volume of saliva. So everything starts to become drier. So you noticed earlier, decrease in tear production, so decrease in saliva. So again, goes into being able to taste things and be able to digest things. Dental loss, you get folks with dentures and unfortunately for a lot of the elderly population, they're on a very tight budget, or their medical insurance, they have Medicare with a supplemental. So they go to get dentures and they get ill-fitting dentures. So I see a lot of times they're like, you elderly patients that don't have any teeth, I'm like, yeah, they hurt to wear them, okay? So then they don't eat, that becomes a problem for them. Gastric secretions are reduced, so again, winds up with issues with nutrition, wanting to eat. Gastric motility slows down, so they wind up with lots of issues with constipation. We run lots of geriatric patients. And then so you take a geriatric patient that all these things are happening to them because of the aging process, and then their doctor has them on all these polypharmacy. Like, what do you think? Like, you can actually wind up with patients that become so constipated, they wind up with a bowel obstruction or a perf bowel. I ran a lady that had been having abdominal pain for days. She had bowel obstruction and perf. So her abdominal contents and all that was leaking into her abdomen. She was very, very septic. I don't know how, she just was a tough old bird, but she recovered from it. But by the time she called us, she was so sick. You're like, you're just constipated. Well, in the elderly population, that's not always just that simple. Not always, well, you're just constipated, okay? So diseases in the bowel, impaired liver function. So what does the liver do for us? Filters everything, right? It filters toxins. So if your liver function is decreased and you're on this polypharmacy, how easy do you think it is to wind up with toxicity from medications? Not that they're overdosing, they're taking their everyday daily dose, but could you end up with a patient that's impaired and is got a toxic buildup because their liver function's down? So things you have to think about with these folks. All right, so GI bleeds can result from inflammation, infection, or obstruction. So how many elderly people do you think take NSAIDs on a daily basis? We know what NSAIDs are. Ibuprofen, so non-steroidal anti-inflammatories. Hey, what do those do to your gut? They eat it up, right? When you take it on a regular basis, chronic use, they eat it up. Like my mom has a form of muscular dystrophy and is disabled. She has a lot of chronic nerve pain. And so she likes to pop, the Advils and things like that. And I'm like, Mom, you can't do that. Like we're gonna have to figure something else out. She'll go to Walmart and buy like the big bottles. I'm like, no, we got to do something different about this situation, okay? Because you're gonna wind up eating your gut alive, or you're gonna wind up with toxic levels, and next thing you're gonna be in the ICU because you've got this toxic buildup, okay? So a lot of the times you see these patients with a high NSAID use. So it breaks down the linings of the stomach, so you wind up with ulcers. Those ulcers start to bleed. Next thing you know, we got patients with a GI bleed. Okay. Most of the time, you're going to wind up with patients reporting dark tarry stools. Okay. So so you have dark tarry stool. Where's that blood coming from? What's happened to that blood? It's been digested. Okay. So you got bleeding in somewhere in the upper GI. So you have dark tarry stools. You have an upper GI bleed. People think, well, it's coming out the lower end. Yes, it is, but it's because it's been digested, okay? All right, so patients with diverticulitis, we run that a lot anymore. I don't know how many patients I run with diverticulitis, new onset diverticulitis. I took a 42-year-old lady to the city the other day with acute onset of diverticulitis. So like I said, you don't have to be 65 for these things to start happening to you. So bleeding in the upper and lower GI system. So most of the time, if you have bright red blood from the rectum, where is that blood coming from? Anybody ever had hemorrhoids? Those can become really nasty in the elderly population. And why do they get them? And why do they become so bad? Because they become constipated and they strain to go to the bathroom. The next thing you know, they wind up with hemorrhoids. So they try to have a bowel movement and they irritate one of these things. So I've taken elderly men to the city to get a hemorrhoid cauterized because it's bleeding so bad they can't get it to stop. Okay, so the things we get to look forward to. All right. All right, so peptic ulcer disease, gallbladder disease, bowel obstruction. So you have a patient complaining of especially upper quadrant abdominal pain. Usually my first question is, do you still have your gallbladder? Because they're like, it hurts here and it kind of hurts like all the way up from here to here. Do you still have your gallbladder? Yep. Well, that's probably my, the top on my list. So folks that haven't had their gallbladder removed, that it seems like one thing turns into another. Gallbladder needs to be taken out. Next thing you know, we end up with diverticulitis and all these GI problems. Ask the patient about NSAID and alcohol use. Okay, so everybody's like, Grandma doesn't drink. So I have picked up an 85-year-old lady off the ground in front of the bar in Chilhowee before that busted her head wide open because she'd been in there drinking Natty Light for 6 hours. Just because you're 90 years old doesn't mean you stop drinking beer, okay? In Chilhowee. Okay? All I had to say was Chilhowee to explain the situation. If you live in Chilhowee, I'm sorry. I don't mean to offend you. But that's, yes. The little, I don't even know if that little bar is even open anymore that says they're on 2 highway. Is it open? Shut it down? Okay. Yeah. She walked out the front door, tripped over a railroad. They used to have like the railroad, what do you call those things? Yeah. They used to have those out there as like parking blocks, I guess, so people wouldn't run through the bar when they pull up drunk. And she walked outside and face planted in the parking lot. Okay. So checking for orthostatic vital signs. So think about it. You have an aging cardiovascular system, and you have an elderly patient that stands up too quickly. You think their heart, the preload and afterload can keep up with that change. Well, so you get patients that become orthostatic, they become lightheaded, dizzy, tell you they're going to pass out on you. Okay, it's very common to have patients with orthostatic vital signs in the elderly population. All right, so acute abdominal non-gastrointestinal complaints. So abdominal complaints to me are always a little bit complicated, especially if they can't be specific about them. If they're just like, I just had this generalized abdominal pain. So it doesn't hurt more in any one area than the other. No, it's a generalized abdominal pain. Well, how much stuff lies in the abdominal cavity? I don't have a CT scanner or X-ray vision. So abdominal complaints can be very broad. You can wind up with a list of 10 different differential diagnoses, and you can't rule out any of them. You're like, well, is it a trauma? No. Is it medical? Well, do they have heart failure? Is it their lip? Because if they can't be specific, you don't have any outward presentation. You're like, I don't know. Okay, so it can be difficult to pinpoint abdominal complaints at times. So you just have to be thorough, look at all the things, do the best you can, treat them appropriately. They need oxygen, give oxygen, keep them in a position of comfort. If they tell you that sitting up hurts too much and they need to lay down, put them in a position that's comfortable for them. Okay. So most serious threat from abdominal complaints is blood loss. Okay, so those that were here for PHTLS over the weekend, I showed a video, and if we have some time on the so I pull it up, but it was a spleen and liver injury from a motor vehicle accident. So if you don't know, you can actually fracture your spleen. But this patient wound up with laceration on both sides. Emergency abdominal surgery, open them up. How much packing went into that abdomen? You're like, can you put that much into an abdomen? And you can, and then they leave it open because what's going to happen? Do you think that they caught all the bleeders on the first try? No. Chances are that patient went back to the OR probably a couple hours later. They fixed something else, packed them some more, and they're just going to just keep packing. And that's the problem is unless you start to see external signs and symptoms, and some patients compensate for it better than others. It may be they've bled 600 mils into their abdominal cavity before they start to show signs and symptoms of shock. Your elderly population is not going to compensate that well. But you can lose an awful lot of blood into your abdominal cavity, as you guys saw. How much blood, they split that guy open, how much blood was pooling, how much clots did they pull out of his abdomen? Large clots. You guys notice the clots that they pulled out and threw on the floor? Okay. All right, so your abdominal aortic aneurysm is one of the most rapidly fatal conditions. Again, like I said, you're dealing with a vessel that's the size of a garden hose. Okay, so you think about the human body. So men and women have a little bit of a difference, a couple hundred mils difference when it comes to blood volume, but you know typically about 5 liters. So if you take 5 1-liter soda bottles, that's about the amount of blood that you have in your body. So you attach a garden hose to the bottom of a Coke bottle and you punch a hole in it. How quickly is that liter going to flow out through that hole in that garden hose? Think about it like that. You touch a garden hose into a liter Coke bottle, you punch a hole in the garden hose and you turn it upside down. How quickly is it going to run out? Real quick, like in a hurry. Okay, so you can see how these types of issues can be fatal so quickly. Okay. All right, so changes in the kidney, so reduction in renal function, reduction in renal blood flow. So what do our kidneys do for us? They help regulate electrolytes. They help filter things from the body. So, you know, how much stuff do we pee out? Pee out glucose, pee out some of the medications, right? Even some of the, like, eat asparagus, right? So even some of the foods that, I mean, our kidneys are also our filters, but they also help us balance our electrolytes. So over time, so your cardiac function goes down. What does the heart, what electrolytes does the heart rely on to regulate itself? Sodium, and one more. Potassium. So it works on the sodium potassium pump. Okay, so if your kidneys are hyperactive, which a lot of elderly people have hyperactive kidneys because they're on what type of medication? What type of medication makes you go pee all the time? Water pill or Lasix? Okay, a lot of elderly people are on Lasix. So that's a significant finding in that polypharmacy. Okay, so when patients aren't, they're not drinking enough, but they have all this output, what do you think it does to your electrolytes? Flushes it out. Okay, so Lasix can become real nasty for people. Also HCTZ. So hydrochlor, I can never say it right. I have to say HCTZ. Most people know what I'm talking about. This is a tongue twister for me. It does the same thing. It's a diuretic, even though a lot of times it's used for blood pressure control and maintenance. My brother-in-law was put on it several years ago. It was like, well, my nephew was small at the time. He was put on it for his blood pressure. And I was actually working out at House 4, and my dad calls and he's hysterical, and he's like, they just put Justin on a helicopter. My brother-in-law is 3 years older than I am. So, we're not far apart. And he's like, we just put Justin on a helicopter. I'm like, what? It's like 1 a.m. I'm like, what are you talking about? So he'd been put on HCTZ about 2 weeks before for blood pressure. It caused a horrid electrolyte shift. He was dumping sodium because he was increased urination. It also has a diuretic effect, so he was dumping his sodium. Was feeling bad, got up one night, went to the bathroom, and my sister, just because she sleeps like the dead, just happened to hear him hit the ground, had a seizure, went in cardiac arrest. And he coded 4 times between the house in the ER bay at the hospital in Texarkana. And luckily, he recovered well from it, but HCPZ caused it. He had extremely low sodium. My old, one of the directors used to be at Higginsville EMS. He was a chronic alcoholic, drank himself to death. He'd come to work sober enough to make it through, which luckily he worked in the office, but he drank himself to death. He had a similar incident due to alcoholism, created a sodium shift. Sodium was critically low, had a seizure, went into cardiac arrest at home. So those electrolytes getting off can be very, very significant in folks. There's lots of times a crew will come in and talk to me about a call, and they're like, I ran this patient and I just don't understand what was going on. And I'm like, what did their lab work look like when they got into the hospital? Well, their sodium was off or their potassium was off. Well, one of the most important organs in your body works off of sodium and potassium, right? So if those electrolytes get off for whatever reason, you're going to wind up with cardiac arrhythmias, okay? And some of them can be fatal, all right? All right, so GIGU, decreased bladder capacity. So there's lots of little folks that can't pee. You get little men that have prostate issues. Okay, you get little ladies that have had multiple kids, and what happens to their bladder? Have I ever had a bladder prolapse? There's the big thing a while back about lawsuits because they did those surgeries where they put in mesh to try to help women that have bladder prolapse keep their bladders in place. Okay, so stuff starts to fall out. All right, I've had there's a lady that used to live at a facility here in the county that we ran her quite frequently for rectal prolapse, and you get there and all her insides are hanging out, and you're like, well, this is terrible. You take her to the city, they shove it all back in, sew it back up, and then 6 months later she'd have the same problems. So unfortunately, the aging process really sucks for some folks. Okay? All right, so incontinence. So this is one of the biggest things. So, over time, your bladder loses its elasticity. People start to have issues being able to control, the urge to urinate. So hence why when you go to Walmart, they have like a whole aisle dedicated to Depends, right? So you start your life in a diaper, end your life in a diaper. It's a vicious cycle, okay? It can lead to skin irritation, skin breakdown, and urinary tract infections. So nursing home patients see this a lot. A lot of patients, doctors are like, well, they can't get up to go to the bathroom. We're going to put in a urinary catheter. And you get there and the urine in the urinary catheter is brown. And you see crystallized formations in the tubing. And you're like, well, they have a UTI. That's why they're febrile. That's why they're altered. Or, they're not changed regularly and they set in those diapers for extended periods of time, especially elderly females. And I'll tell you that even a new onset UTI in an elderly female can cause a massive change in mental status real quick, like in a hurry, even before they start running a fever. So if I run an elderly female and she has history of UTI, and I'm like, she just got confused this afternoon. Has she been going to the bathroom? That's usually the first thing I ask about is if she's had a UTI. All right, urinary retention. So this is more seen in males with prostate issues. They wind up having indwelling catheters put in. Okay. All right, so the endocrine system, so reduction in thyroid hormones. So most of these folks wind up with hypothyroidism. So they wind up on Synthroid or something like that gets thrown into their polypharmacy. So signs and symptoms, you may see a slower heart rate, fatigue, dry skin and hair, cold intolerance, which elderly folks are already cold intolerant for the most part. You may have some weight gain. All right, so HHNC, or it used to be called HHNK, we called it HONK. Okay, so these are your patients that are type 2 diabetic. These typically are patients that are poorly controlled, insulin-dependent diabetic. Blood glucose levels on these folks are usually over 1,000. So you don't typically see, DKA, you're going to potentially have the fruity breath, They're gonna have increased urination, increased thirst. But for the most part, they're still pretty typically, the medication is still pretty good. With these folks, they may be comatose by the time you get to them. Like I said, most of the time, our glucometers are just gonna say hi. They get to the hospital, draw labs on them. I had a guy ran in the trailer park on West Young. Son called and was like, he's like unresponsive and he's drooling everywhere. And I mean, this guy was soaking wet by the time we got to him. You couldn't get him woke up. We thought it was drug related because we had been to that residence before for drug related issues. And so, you know, we did the Narcan and checked the sugar and it just read high. And this guy, I mean, he is like completely unresponsive. Vital signs were unstable. Wound up having to intubate him because he couldn't maintain his own airway. Got him to Western Missouri. His blood glucose was 1,800. His organs were cooking from all the sugar in his system. Okay. So it can be really, really nasty. I said these patients most of the time are comatose on you. All right, so the immune system. So elderly folks aren't able to fight things off like we are. So they're less. So they're more prone to things like UTIs, pneumonia, especially when they're bedridden. Okay. Musculoskeletal system. So decrease in bone mass, especially postmenopausal women or women that have had multiple children, because having babies sucks all the calcium out of your body. And so if they, you know, even those women that are on calcium supplements for the most part, it doesn't counteract the aging process well. So they wind up with osteoporosis. Again, that's why, especially elderly females, it doesn't take much for them. I said, the little lady that just stepped off of her porch, just the normal everyday thing that she normally does, coming out off the porch, stepped onto the ground, her hip shattered on her. Okay. All right, so strength declines, ligaments and cartilage of the joints lose their elasticity, things start to atrophy. You can also get patients with kyphosis. You know what I'm talking about when I say kyphosis? The hunchback of Notre Dame. Like that's literally what it is, a hunchback. So I ran a lady, North House 2 the other night. Got called, she'd been having trouble swallowing anytime she eats or drinks for several weeks. And so we got there and she had vomited and like her eyes were bulging out of her head and tongue's hanging out. And the son's like, I think she's gonna die. And I'm like, yeah. Cool story. Like, thanks. Oxygen saturation was 70%. She'd aspirated. Well, the doctor at Western Missouri, of course, thinks it's COVID. And I'm like, whatever. But anyways, so she had really bad kyphosis. Like she didn't weigh much. So we like scooped her up to get her out of the house because we couldn't get the cot in there. So, you know, you slap her on oxygen, you start moving her. And I'm like, I'm gonna have to intubate this lady. And this is going to be terrible. This is going to be like that. I mean, you think about it, you have to lay somebody flat and they have kyphosis to try to establish an advanced airway. It's a nightmare. So I called, you know, for 6,100. We wound up getting her on BiPAP, getting her turned around without having to intubate her. But things like that, you're like, how am I going to pad her to get her in the position I need her to be able to intubate her? Like, this is going to suck because what also happens, so they become kyphosed. So they get the curvature, and what happens to their neck? It becomes non-existent. Their airway structures become super anterior, so they become a airway nightmare at that point, okay? All right, so osteoarthritis, you run into folks that tell you they have, you know, their knees hurt, their back hurts, all their joints hurt, okay? It's a very common thing. All right, so changes in skin. So over time, it becomes thinner. So skin tears are super common. You get patients, especially little elderly ladies. Like I said, when I start IVs on elderly folks, if I can get the tourniquet over a piece of clothing, I always try to do so to try to alleviate a skin tear. Because I've created a skin tear with a tourniquet, not on purpose, but just because their skin is so thin, you go pop that tourniquet and it slides off and it takes a piece of their skin with it. I said, you know, it's never intentional, but you just have to understand that their skin is so thin and so frail that it doesn't take much to tear it, and it will bleed like a stuck pig whenever you do. Okay. So sweat glands do not respond as readily to heat. So you can also have these folks that, they get out. I read some out at the air show a couple years ago. Family had gotten their veteran dad out of the nursing home, out of the veterans home here in Warrensburg, had brought him out to the air show. And have any of you been out to the air show in July? It's never cool out there, and you're on concrete. There's very little shade. It is hot. And so they had him out there, and of course, he's that, Vietnam veteran that, he's got his cap on and he's wearing a sweatshirt because they're still freezing cold. But they don't acclimate to the heat. They don't start to sweat. They don't realize that they're getting hot because all they ever know is that they're cold all the time. And wound up having to transport him for a heat-related emergency because they had him out there. He wasn't drinking water in a sweatshirt. And by the time they got him to me, he was red as red could be, but he wasn't sweating at all. So, just some things, family felt terrible because they're like, we didn't realize that he was getting overheated out here. He wasn't sweating. Well, changes with age. All right, so pressure ulcers. These can become super, super nasty for the elderly population. You see this a lot in nursing homes. They wind up with the decubitus ulcers on their backside because it's usually, they don't get rotated well enough. They don't get, put on their side. There's, like the veterans home, I feel like does a fantastic job with their care out there. The patients have the beds that'll rotate them or the air beds that take pressure off, but not in all nursing homes do that. So a lot of times you get these patients that have, and I've gotten patients to the hospital, and in the nursing world, doing a skin check is like a huge thing as part of like your initial assessment. Like that's a huge thing. They check every inch of the skin. So I've helped, a few times I've taken patients in, nurses asked me for it, like, can you help me roll them so I can check the back to document. And I've seen these decubitus ulcers that have, they're this big, right on, the right above the bottom. And it's eaten down to the bone. Just horrible, nasty bed sores. They become infected, and you're like, well, I don't see a source of infection until you roll them over, and you're like, there's the source of infection. That's why they're septic, is they have this nasty, huge bed sore on their back. Okay. All right, so toxicology. So older people are more susceptible to toxicity because of decreased kidney function, altered GI absorption, decreased vascular flow in the liver. It's like we knew that was coming, right, from what we talked about earlier. Okay. So decreased liver function makes it harder to detoxify the blood and eliminate medications and alcohol. So these patients that have the polypharmacy, it's easy for them to become toxic, for these medications to create toxic levels in the bloodstream. Okay. Digitalis is a cardiac med, and it is notorious for creating toxicity in the elderly population. And you will see cardiac arrhythmias, you'll see altered mental status, you can see some really nasty things with that. All right, so poison control. So this is this is a number that's good to have for the elderly and for the kiddos. Okay, so you have a patient that tells you that they took too many of this medication on top of all these other medications, and there's so many new medications hitting the market from month to month that even the most seasoned, experienced paramedics like, what is that? And you Google it on your phone and you're like, well, it says it's for this, but they're saying I take it for this, and then they take all of this. So if you're ever in doubt, the Poison Center can help answer your questions about medication interactions, overdose, what to do for patients. I've called them on some pediatric stuff before. A kid ingested something and they're like, tell the parents to give them a glass of milk. Like, really? I'm like, yeah. Like that's what, when that's ingested, that's our recommendation, is a glass of milk. I don't need to transport them. No, they just need a glass of milk. Okay, cool story. But if I hadn't called them, I wouldn't have known that. So they're a great resource to have in your phone. All right, so typical over-the-counter medications can have negative effects when mixed with each other, especially So you get the little old ladies, you know, that I ran a call last year, and they actually, like, I don't have to sit down and talk to a state investigator over it. They come in, so ran this call up north of Warrensburg, really nice old farm home, nice elderly couple. They both had dementia, but they were able to still function at home well. Like the house was clean. They were, you know, well cared for, clean clothes, like, you know, they were doing just fine. But this, he was a DO chiropractor out of Blue Springs that somehow managed to find this elderly couple, and he, you know, convinced them, like, the wife was like, well, he comes down and hunts on our land. I bet he does. And so on the counter in their kitchen was this box, and it was about the size of, you know, like you go to the grocery store and like the canned good flats. It was a box, like big old box, and it was full of herbal supplements, all kinds of random weird things, like stuff we'd never seen before. And it had medication labels on it, like it was prescribed to him from this doctor. And she's like, well, he just mails them down here to us. I said, like, so do you take any like prescription medications, like, you know, anything for any known, what kind of medical problems does your husband have? I mean, this guy, we were struggling to figure out, is he having a stroke? Like, what is going on here? And so this doctor had put this guy on all these supplements, and you get to looking through them. And at that time, I didn't know a whole lot about polypharmacies when it comes to herbal supplements. And you got to looking through there, and some of the interactions between herbal supplements was detrimental. So anyways, long story short, this doctor was frauding these elderly folks, sending them all these supplements. And this guy had a terrible electrolyte imbalance. He was presenting with stroke-like symptoms, but they weren't. You just could tell something wasn't right. You're like, but it doesn't seem like a stroke. Like one minute he can speak clearly, and the next minute he can't. And he's got dementia, but, you know, like something's just not adding up here. Well, he had toxicity from herbal supplements he was put on. So turning this whole big thing. But at the time, you know, me and my EMT partner were like, what? Like, I don't understand why this is going on. Okay. So you had alcohol, over-the-counter stuff. So something as simple as the little old man, the little lady goes to the drugstore to get some cough syrup because they've got a cold, and starts taking it, and it interacts with one of their prescription medications. And you can get called for altered mental status or them having some adverse effects. So, you know, making sure you ask, have you added anything to your medications recently? Have you stopped taking any medications recently? Are you taking any over-the-counter stuff? You know, things like that. You have to, especially when you identify there's a polypharmacy you're dealing with, asking those types of questions can lead you down a track. All right, we've talked about the polypharmacy. So medication noncompliance. Okay, so unfortunately in the elderly population, a lot of folks are living on a strict budget. And there's months where, you know, I encounter it and see it that, you know, they have to choose between eating and getting their meds. So they'll say, I couldn't afford my meds this month, so I haven't had my blood pressure medication in 2 weeks. I haven't taken my Lasix in 2 weeks. So you take a patient that's been on a blood pressure medication and Lasix and some of these other cardiac meds for years, and all of a sudden stops taking them. What do you think is going to happen? They're going to have all kinds of problems real quick, like and in a hurry. Okay, so understanding that dynamic, you know, asking those questions will be important. Inability to open containers. So a lot of times, you know, caregivers will come in and you'll get the Monday through, you know, Friday medication trays, right? And for some folks, that's great. And then for other folks, like, you're like, well, where are the pill bottles so I know what this stuff is? And they're like, I don't know. So all you get is this Monday through Friday medication tray with all these colorful pills, and I don't know what any of that is, okay? Impaired cognitive, vision, and hearing ability. All right, late the other day, she just forgot to write down that she had taken her beta blocker pill at 7:30 in the morning, and then she turned around and took another one at 10:30 a.m. So she'd only taken a total of 25 milligrams. In this particular medication, they don't call it an overdose until you've taken 50, but she was concerned and called, and understandably, because what does beta blocker medications do? You may know what beta blockers do.
Lower your heart rate.
They lower your heart rate, okay? So you double up on something like that, what do you think could potentially happen? You're gonna be dizzy, you're gonna be lightheaded, your heart rate's gonna be low, your blood pressure's gonna be low, you're liable to have a syncopal episode and you go to stand up, okay? So she was concerned, called us, we took her in, got her checked out. All right, so depression. So we see this a lot, especially in nursing home patients. And you will even see they are on a polypharmacy of antidepressant, they'll be on 3 or 4 different things. Doctors determine, they have all this anxiety and depression, so they put them on 3 or 4 meds, which becomes a problem for them. If unrecognized or untreated, is associated with a higher suicide rate in the geriatric population than any other age group, okay? So when we do GYMS, which is, it's an EMT class, one of the things that always catches people is the suicide rate amongst the elderly population. It's actually very, very high. And the most common thing that they use is firearms. But the suicide rate in the elderly population is actually very, very high. Okay. Older men have the highest suicide rate of any age group in the United States. Okay, so, and they're talking about with this 65 years and older. Okay. So like I said, firearms is the number one used item here. A lot of times, it's just like with any other age group, you never see it coming. They don't complain about anything, especially in this age group. How many old elderly men that are, were Vietnam veterans or old farmers are willing to admit that they're depressed? No, they just go out and handle it out in the pasture. Okay. All right, so the GEMS diamond. So this is just an assessment tool that we use. I said we teach this in our advanced level classes. So this is created to help you remember what is different about older patients. Okay, so it's just an acronym that can guide you with your assessments. So one, you have to remember you're dealing with a geriatric patient. Okay. An environmental assessment can help give you clues of patient's condition and the cause of the emergency, okay? So if you go into a patient's house, say this time of year, today, obviously it's been warm lately, and then all of a sudden Mother Nature in Central Missouri decided to change the temperature today. If you were to go into an elderly person's house today and you walked in and it was cold, would that be a red flag? Yeah. You go in and there's no food in the fridge, or they tell you, or they don't have any electricity or running water, or you notice that the home is disheveled or they're not clean. How many old people on the norm do you know that are unkept and unclean? Not very many, honestly. People 65 and older, typically it's not something that you frequently see. I would say it's a very small percentage, because here in Johnson County, we think, oh, there's a lot of nasty folks in Johnson County. True, I've been in those homes. I've almost fallen through the floor in some trailer homes a few times. I've seen the nastiness, but for the most part, even your low income folks, your low income elderly people, their home is clean and kept. They may not have much in it. There may not be much to it, but it's clean and it's kept and it's tidy. Okay. So anything outside of that usually is a little bit of a red flag. Now there's people that are just dirty and you'll be like, they've probably been like this their whole life. Okay. So, but for the most part, it's not something that's super common. So medical assessment, obtain a thorough medical history. Okay. So like I said, a lot of the times you ask these folks, what kind of medical problems do you have? I don't have any medical problems, but I have this whole case of medications. Okay. So you may have to sift through, you may have to investigate, you may have to pull out Google on your phone and be like, what is this medication and why would they take it? Oh, well, you have AFib. That's why you take it. Okay, now I understand. So you may have to be an investigator here and do a lot of the work yourself, all right? And then social assessment. So older people may have less of a social network and need assistance with daily living, okay? This is also something too, like I talked about earlier, that you get into a certain age group of folks and you get to talking to them and you start to realize they're depressed. I said their spouse has passed away all the people they've known have passed away. Their children may have already, like they buried their spouse, they buried their children, they buried all their friends, and here they are, okay? So lots of things go into a social assessment for the elderly population. And people always like, assisted living communities and things like that. A lot of those people flourish when they go to assisted living communities, like the vineyards here and some of these other places. When we go into those places, the majority of the time, the folks in there, you can tell that you can tell a difference going in those facilities versus a nursing home facility. Like it gives them a social network. It gives them people to talk to. It gives them people to play bingo and cards and go down the hall and have somebody, a neighbor to talk to that's their age. So those facilities actually can be very beneficial for people as long as they're managed well. Okay. All right, so some special considerations. Again, remember your communication issues that you may have to get creative. As I said, you may be writing questions on a piece of paper and, a yes or no, thumbs up, thumbs down. You may have to come up with something that'll work, okay? Remember the hearing and vision deficits, and remember though that not every elderly person is hard of hearing and can't see, okay? So make sure that you approach them like they aren't. And then once you identify that they are, then you can start talking louder, or you can start changing the way you do things. But don't walk in and assume that every elderly person cannot hear you. Alterations in consciousness. So just like with pediatrics, ask, is this normal or is this not normal? Or what is not normal today? When did this change? Was this a sudden onset? Has this been progressive for a few days? Find out what changed over what period of time. Is new medication started? Do they have history of UTIs? Are they diabetic? Start to delve into and figure out what's going on. Complicated medical histories. So, like I said, the CHF, COPDers. So underlying medical conditions that just compound upon each other. So the next thing you know, you just have a hot mess express, like the choo-choo, like hot mess, okay? You have all these underlying medical conditions, and each one of them just makes everything else worse, okay? And then effects of medication. Again, the polypharmacy, you look through those medications, have a general understanding of pharmacology and what might cause some issues, what medications may interact. If the patient tells you I've taken too many of this medication, what are some of the potential risks and side effects? And if you don't know, call medical control, call poison control, call somebody and find out. All right, so make sure you do a good scene size up. So, walk in and take in the environment that you're walking into. A lot of times the environment that you walk into will tell you an awful lot about what's going on, okay? Just looking around, taking in, sights, smells, like, sometimes calls are a sensory overload with geriatric folks, especially, you get the little lady that's got all the cats. Something about ammonia in a house with a bunch of cats is very overwhelming for me. Like I get very distracted with it. And I have to I just get short of breath and we've even had some folks here that are so allergic to cats. Like there used to be a medic here that she'd have to stand outside and the EMT have to bring the patient out, So, there's times where you get a sensory overload walking into these folks' house. But all these things start to tell you pieces of the puzzle. Okay? Many older folks live alone because they don't want to give up their independence. They don't want to give up the home that they've lived in for 50, 60 years, okay? And having to take them out of their home and take them to the hospital sometimes is very traumatic for them. Access may be hampered if their condition prevents them from getting to the door. How many times do you ladies phone fire or police for access into elderly people's homes for us? A lot, right? The fall down, go boom, the medical alarm, there's a lady holding her cat always steps on it. So we get there and scare the hell out of her. It's always like 4 o'clock in the morning. And and she sleeps in the front bedroom of the house. This is how many times the cat has stepped on it because you know where she's going to be. It's 3 o'clock in the morning. The cat has stepped on her, first alert. And you get there and you peek over the window and there she is snoozing in bed. And you're like, I have to rattle this window and wake this little lady up at 3 in the morning to tell her to go turn off her first alert because the alarm company is, freaking out. And, you rattle it. She's scared. she comes flying to the front door and you're hoping she doesn't trip and fall and break her hip, and it's a mess. But there's also times where you get that little lady that's fallen and can't get up, like the medical alarm commercial on TV, and you have to get somebody to come help you get in. Take note of negative or unsafe conditions. So again, the little lady's house that is freezing cold in the middle of winter. There's no lights on, there's no food in the fridge, things like that. You always get your mechanism of injury or nature of illness, figure out what you're dealing with. Remember that, if the patient can't give you the information, see if there's someone else on scene that can. Also, like, we used to push it pretty hard. A lot of people use it, the vial of life. So they have a sticker on their front door that says medication or medical information in the freezer or whatever. And so we used to go around and it was literally like a medication bottle from the pharmacy. They fill out paperwork, put it in there, and a lot of people just keep it in their freezer. So sometimes they'll have an access to medical information stashed somewhere that you can get. Just like with anything else, address life threats, determine the priority of transport, okay? Make sure that you determine sick, not sick, stable, unstable, and go from there. Airway and breathing. Again, if they don't have a patent airway, they're not breathing adequately, just like with any other patient, you need to address it and treat it appropriately. Circulation, so you have exsanguinating, life-threatening bleeding, even in an elderly patient, you need to stop it. And what do a lot of elderly patients take that make bleeding control a nightmare at times? Blood thinners, okay? So you get the little old lady that's on Coumadin, and she falls and whacks her head and just has a little bitty head whack, but you can't get to stop bleeding to save your life. Or the patients that have dialysis shunts, that they wind up tripping and falling and nicking their dialysis shunt and they're on a blood thinner. You want to talk about somebody that you bleed to death, yeah. Or varicose veins. I ran and called it the Love's truck stop up at the Higginsville Junction a few years ago. Truck driver, he was diabetic, poor overall health. Like you could just look at him and go, this guy is poor health. We got called out there for, I don't remember what we got called out there for, but we get in there and he's in the bathroom, in the men's bathroom, in a stall, sitting on the toilet. And we walk in and there's blood running out from underneath the door. And I'm like, do we need law enforcement? Like, what is happening in here? And he literally had a pinhole size hole on the back of his leg and a varicose vein. And he was bleeding all over the floor. Like, I mean, massive amounts of blood. I mean, this thing was spurting. Like it was shooting across the stall and hitting the wall and running down into the floor. So, put a pressure dressing over it, got it stopped. But he's diabetic, had poor peripheral, he had the nasty diabetic legs. He was on blood thinners and all kinds. I mean, it looked like a murder scene. And all it was a little bitty hole on the back of his leg and a varicose vein. Okay. So the polypharmacies can complicate bleeding problems. All right, make a good transport decision. Investigate the chief complaint. So, just like that second part of your medical assessment, make sure that you're assessing body systems, make sure you're not missing something. Get your sample. Get head to toe, vital signs, especially in the geriatric population, training vital signs is very, very important to look for, subtle changes in things, or, identifying an irregular heartbeat, asking them, do you have history of an irregular heartbeat? Well, no, that's a significant finding. Okay, so sometimes your vital signs will tell you things, again, like your beta blockers. Your beta blockers can mask signs and symptoms of shock. So an elderly patient that's been involved in, say, a motor vehicle accident can have internal bleeding, and their heart rate will never get above 80 beats per minute because they're on that beta blocker, but they're bleeding internally and going into shock. But you're like, well, they never became tachycardic. Well, no, because they take beta blockers. Their heart rate's not going to get tachycardic. They take a medication that inhibits and does not allow the heartbeat to get above 80 beats per minute. Okay, so getting a good history and understanding the whole picture will help you out. So yes, medications will mask signs and symptoms of shock. You won't get typical presentations with these folks. All right, so blood pressures tend to be higher. Again, that's due to the changes in the cardiovascular system. And you may have really high systolic blood pressures, and your diastolic pressures may be what you consider normal. That you get those wide maps. That's just the way their body ages. Okay? Cap refill is not a good assessment because what happens to the periphery over time? Look at old people's hands and feet. What do they look like? Poor circulation, right? So cap refill is not a good assessment tool with these folks. All right, so reassess, reassess, reassess. If they're stable, every 15, unstable, every 5, okay? Here's a table from your book. All right, so trauma in geriatric patients, again, we talked earlier, you know, things like blood thinners can complicate trauma, beta blockers can complicate trauma in identifying signs and symptoms of shock with these folks. Physical findings may be more subtle and easily missed. Again, they may have, you know, internal bleeding and you don't notice it until they become altered and are going down the drain on you because they're on that beta blocker and you never saw their heart rate increase. All right, so we talked earlier about high risk of burns and why is that? The nervous system slows down, okay, because the impulse, you know, where you and I touch the stove and our nervous system says, pick your hand up, stupid, like their response to that is way slower, okay, so they're gonna wind up burning themselves a lot easier. All right, so higher mortality rate from penetrating trauma, obviously, because you get in the population on blood thinners, so you get these serious, significant penetrating injuries or life-threatening traumatic bleeding, it's going to be way harder to stop. Okay? This stuff, the brain tissue, talked about that. Sorry folks, some of this stuff duplicates itself. There's no reason to go over it twice. Okay, so patient with a hip injury or pelvic injury that you're concerned about, what's a good way we can package these patients, move them around?
Like put them on a sheet, just lift them.
Yeah. Put a sheet underneath them, wrap it up tight, put them on a board, move them, things like that. Okay. A lot of what we do is being very creative with our lifting and moving of patients, as you guys saw in the room the other night. How easy was that to move her around? If you think that you don't have elderly patients that act and behave like that and family members on scene that'll act and behave like, that's mild. So how hard was that though to move her around in those circumstances and get her out of there? Anybody think it was easy to do? Yeah. So that is very, very realistic. So you got to be creative with your lifting and moving and packaging of these folks. Or what if you have the elderly lady that's got the kyphosis, that's broke her hip? How do you package? How do you get her on a scoop stretcher comfortably to get her carried out of her hoarder house? You got to pad a lot, right? You're probably not going to have enough blankets and pillows on your truck to do it adequately. Okay? So we go to nursing homes and skilled care facilities a lot for geriatric patients. I'd say between psychiatric calls and nursing home calls, those two numbers combined, I was just a guess or throw a number out there, would take up 75% of what we do. You ladies get called from the nursing homes a lot. You probably get called from them. Would you say it's a fair statement to say that we go to nursing homes more than we do much of anything else, especially here in Warrensburg trucks? Yeah. You know, I don't have a firm number to throw out there, but I guarantee if we ran them, psychiatric calls and nursing home calls are our two. That takes up the majority of what we do. The cool stuff takes up about 5%. All right, so infection control, so things to be mindful of, MRSA, you can get in C. diff. There's lots of nasty things that can run around nursing homes, and if one of them gets it, it doesn't take 2 days for the whole facility to have it, okay? So that's where folks like dispatch that give us notifications, like respiratory precautions are mandatory at this facility because everybody has COVID, okay? Especially right now, with COVID, it's a thing. You guys have facility alerts on on these facilities, don't you, where it automatically prompts you to tell us? That's what I thought. Anytime I'm getting real tired of wearing that P100 mask. All right, so dying patients. So more patients are choosing to die at home rather than in a hospital. Okay, so lots of folks go home on hospice or palliative care, comfort care, and we get called, because family, as much as they think they're ready, they're not ready. So patient gets to the point where they pass, family freaks out, and we get called. You may have a hospice nurse there. You get there and they got DNR paperwork, and so the majority of what you do is provide emotional support and education to the family. Okay. Make sure that you're empathetic. Be compassionate. Talk to family. It's never easy to talk to family members about death and dying. Okay. Advanced directives. So, anytime, especially if you're going, for someone that's on hospice care or end of life care, and they're like, we want you to do all the things for them. Well, do they have a DNR? Do they have advanced directives that tell us what they want? We want to try to honor their wishes. Okay. So do not resuscitate orders. So here in the state of Missouri, you have to have it in hand in order to honor it. You can't have a family member say, I have a DNR. I need it. I need it physically to say, we're not going to work this cardiac arrest. Okay. So, and this is what it looks like here in the state of Missouri. It is a purple form. Okay. So the original form is purple. Okay. You have a copy? That's fine. I'll work with you on the copy. But ultimately, we want the purple form. Okay. So this is what it's going to look like. I said a couple of the nursing home facilities here are great. Like the Veterans Home, you get a face sheet with information and the DNR form right behind it. And it's there because it's purple and it stands out. Okay. All right, so elder abuse and neglect. We're almost done, folks. So any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's person, property, or emotional state. And I would tell you this happens way more than anybody wants to admit. Okay. So in the state of Missouri, as an EMS professional, you are a mandated reporter for elder abuse and neglect. There's a hotline number you'll see in a moment. I've seen this too much over the years. It's so sad. You have family members that take advantage. Grandma's getting the Social Security check, so they stick grandma in the back corner and don't feed her, don't take care of her, but they've got the 60-inch TV in the living room and driving the really nice car that's parked out front. But grandma's back there in her own filth and hasn't eaten in days. Okay, it happens, and it happens right here in Johnson County more than anybody wants to admit. Okay, so there's a hotline. They also have it now where there's an online form that you can fill out. But I like to call and talk to somebody when I'm calling and reporting either child abuse or elder abuse. I want to call and talk to somebody on the phone. And I'll tell you, these folks are good. There's usually a follow-up real quick, like in a hurry. So the process does work. But like I said, I like to talk to somebody because I want to know that they understand there's just some things you can't type in an online form. Okay? So it's largely hidden in society. Like I said, a lot of the times it goes unnoticed for long periods of time. And then the abuser gets so comfortable with it that the patient gets sick and they call us and don't even realize that they haven't covered up their tracks. And so they allow us into their home and you start to look around and you look at the environment and you're like, there's all kinds of things wrong here. And it's like, okay, we're gonna get grandma out of here. We're gonna get grandma cared for, get her to the hospital, and then I'm gonna get on the phone and call the state and get somebody on this. So in your little old grandmas, oh, my grandson, he needs the money. He needs the money. She hadn't had her medication in months. She hadn't eaten. My grandson, he needs some money. That sweet little old grandma that gets taken advantage of. It happens way too often. Most often occurs in women older than 75. So women are usually the elderly women are usually the greater population that are abused or neglected. Abusers of older people are sometimes products of child abuse themselves. Abuse may also occur in nursing home facilities, care centers. There's been stuff on the news over the years. Like one of the projects I'm working on right now for school is Hurricane Harvey down in Texas. Does anybody remember the images that were broadcast on CNN and everything about the nursing home facility where the little ladies were sitting in water up to their chest? Nobody, that the nursing home staff had left and nobody ever evacuated them. Everybody remember that? 2017? Yeah, like wow. Okay. So this type of stuff happens. You see people getting charged and going to trial for nursing home elder abuse. It exists. Okay. So information that may be important in assessing abuse includes caregivers' apathy about the patient's condition. She's back there in the back bedroom while he sits on the couch eating his Cheetos and watching a 60-inch TV. Okay. Overly defensive reaction by a caregiver. Caregiver does not allow the patient to answer questions. Okay, that's always a red flag when they won't I'm like, well, at some point they're going to be in the back of my truck and I'm going to start asking them questions. And there's been times where it's on the way to the hospital, you get to talking to the little old lady or little old man, and they start to talk and start to open up, and next thing you know, you're like, they're being abused and neglected. Okay, because you get them away from that abuser, they start to open up, and next thing you know, you get the full story. Repeated visits to the ED or clinic, a history of being accident prone. Well, grandma just falls a lot. Okay. Unbelievable or vague explanations of injuries. So same thing with child abuse, bruising in multiple stages of healing. Stories from caregivers that don't match. Injury patterns, all that stuff is huge red flags. So psychosomatic complaints, chronic pain without medical explanation, self-destructive behavior, eating and sleeping disorders, depression, anxiety, substance or sexual abuse history, also are factors that go into elder abuse and neglect. All right, so again, and sometimes this is like in kids, and I always hate talking about child abuse, but unfortunately it exists too. And a lot of times abusers will cover things up. Like if there's ever a time where I have a pediatric patient that's still in diapers, I'm concerned that they're being abused. It's I can't wrap my head around, but exposing kids looking underneath their diaper, abusers will cover things up with that diaper. They'll look fine, and then you remove the diaper and they've got cigarette burns or bruising in multiple stages or whatever the case may be. Same thing can happen with your elderly population, okay? So make sure if you're suspecting of something that you do a good physical exam, okay? Again, bruising in multiple stages, handprints, pinch marks. So that's the special thing with the elderly population is especially as you age, you start to bruise a lot easier, right? So, elderly folks, somebody grabs their arm and presses down, it's very likely they're going to leave a bruise that's shaped just like that, okay? Human bites, look on the upper extremities, lacerations and infections. So the human mouth is disgusting. This stuff unfortunately happens though. So lack of hygiene, poor dental hygiene, poor temperature regulation, and lack of reasonable amenities in the home are huge red flags, things that you need to look for. All right, so your review questions, you guys look through those, okay? We'll get moving into skills. It's 5:08. Miss Barbara made it here. Look at you. Okay. All right. So like I said, it's just the three of us tonight. Everybody canceled. So yay. So Blake, can you do a trauma assessment? Barbara, can you do a medical assessment? And you can pick whichever room you want to be in. If you want to make up assessments, that'd be great. You can hold them to a 10-minute time limit. because after this week, we have one more week, and then they come back, it'll be testing, so. Get it down, okay? So let's number off around the room, 1 through 3. 1, 2, 3.
You said the
One,
green,
yeah.
not one.
Two.
I used to be a third. I didn't hear what she said.
1, so 1, okay, 2, 3, 1, 2, 3, 1, 2. All right, you're at 2.
Yeah, for a reason.
It's okay. Let me talk with these folks real quick that's online.